Welcome to the Perry Health Pulse podcast, a program dedicated to taking you behind the scenes of healthcare, sharing firsthand knowledge from healthcare professionals, and putting you in the driver's seat on your journey to lifelong health and wellness. Listen and learn about how healthcare delivery is changing on our weekly podcast.
On today's episode of the Perry Health Pulse podcast, we're going to be talking about major depressive disorder. And our guest today is Dr. Scott Arbaugh. He's been board certified in psychiatry for 30 years. He's a distinguished fellow in the American Psychiatric Association, and he's also on the faculty of Washington University in St. Louis and at the University of Illinois at the Peoria College of Medicine. We're excited to have him here. He works with the Senior Behavioral Wellness Program, and we'll talk about that a little bit further on in the episode. Thanks for joining us, Doctor.
Well, thank you for having me here.
To start off, I think most people probably don't know the difference between just someone who's got depression and major depressive disorder. Can you explain a little bit about what the difference is?
Well, I think first of all, if a mental health professional uses the term depression, we very often just kind of use that shorthandedly, and we do mean major depressive disorder. But I think in more common speech, people often say, I'm depressed today, and perhaps they're having a bad day because something happened. And there's a big difference between that and major depressive disorder. Major depressive disorder is a medical illness. It's an illness that requires people to feel depressed or unable to enjoy things for at least a 2-week period of time. And when people are depressed, they usually have a number of other symptoms that go along with that. For example, we often see changes in appetite. Generally, people lose appetite and they may lose some weight. We often see that people don't sleep well when they're depressed. Most patients tend to have interrupted sleep, but it can also be hard to fall asleep, and sometimes people tend to wake up early and are unable to return to sleep. When people are depressed, they have poor energy, they have poor concentration, they may feel hopeless, worthless, and some people even go on to develop suicidal thoughts. Now, the criteria from the American Psychiatric Association requires that people have to have at least 5 of the symptoms that we just talked about, and that those symptoms have to be present most of the time for at least 2 weeks. And one of the symptoms has to be low mood or the inability to feel pleasure from things that one would normally enjoy.
How do you go about diagnosing that then?
We diagnose like any other medical specialty. We use that criteria. We interview the patients. We ask them about the symptoms. We say, how do you feel? Do you feel depressed? Do you feel like you're unable to enjoy things? And then we inquire about appetite and sleep patterns. We ask about their energy level, their cognitive functioning, whether they feel hopeless, if they have suicidal thoughts. And that's how we make the diagnosis.
Then can you describe a little bit about what happens to treat major depressive disorder?
Well, the standard of care really calls for using antidepressants. And as you may know, there's a lot of different antidepressants. We've got older antidepressants like the tricyclic antidepressants, which are not really used quite as much as they used to be. And we use a lot of the newer antidepressants, serotonin selective reuptake inhibitors, serotonin norepinephrine inhibitors. And more recently, we have drugs that not only work on the serotonin system, but they also bind to specific serotonin receptors in the brain. So it's been an exciting time in psychiatry with all the changes in medicine. And I think the good news is that depression is really a very treatable condition. Probably we can help at least 80% of the patients.
I was going to say, it's probably an exciting time to be getting some medicines that really do work well, but is it something that's curable?
Depression is not curable. Depression is a chronic illness, and as such, it's treatable. But it's a very treatable illness. What we find is that people who have a good response, and in fact, people who go into remission of major depression, provided that they stay on their medicine, they tend to do extremely well over time. Those patients who don't get all the way well, in other words, patients who continue to experience a few depressive symptoms, they tend to have a little bit more of an up and down course with regard to their depression. But even so, overall, I think we're helping a good 80% of people, if not a little more.
Now let's talk a little bit about the people who aren't receiving the help or who start taking medication, then they decide to stop and they're just really not getting the treatment they need. What can happen emotionally and physically to them?
Well, that's a good question. In fact, about 15 years ago, there was a study that was done, and they looked at the 12-month prevalence of depression. And they looked at the patients who developed an episode of depression during that 1-year period of time. And I'll spare you all the details, but the bottom line is that only about 21% of people actually received adequate treatment. Another 20% received treatment, but the treatment was deemed to be inadequate. And unfortunately, about half of the people received no treatment. As I said, depression is a chronic illness, and we need to put people on medicine, and with minor exception, they do need to be on that medication indefinitely. And most people who stay on their medication and take it faithfully, they tend to do fairly well over time. People who go off of it, obviously the depression comes back, it gets more severe, and of course we're always worried about suicide because depressions can devolve to that level. Physical changes, that's an interesting question. The answer is yes. We do see in depression, I rattled off before a number of the various symptoms of depression, but it's not uncommon for people to be somewhat somatic. In other words, they're depressed, but they may go to their primary care doctor and they complain about headaches or they complain about stomach discomfort. Those seem to be the two most common somatic complaints, but we see that quite frequently, actually.
Now, what about risk factors? Are there things that indicate that a person's heading towards the point of having major depressive disorder to watch out for?
Well, first of all, depression is a genetic illness, and it means that it runs in families. So people who have a family history of depression are at an increased risk for developing an episode of major depressive disorder. Typically, as what we see with depressions, is that the age of onset is actually bimodal. It means we have two peaks. The first peak occurs in young adulthood, and the second peak occurs somewhere around the age of 65. So people who have a family history of depression, certainly should have that in the back of their mind. Now, having said that, what about environmental stresses? Well, certainly environmental stresses can sometimes turn on the genes, and that leads to a person developing an episode of depression. So it's not uncommon for somebody to come in and say, well, I'm really feeling depressed. I've got a lot going on right now. I just got fired from my job, or I'm going through a divorce, or there's serious illness in the family, or there's been a death recently in the family. And these kinds of stresses seem to bring on the episode of major depression.
Well, and it sounds like an important takeaway of that is that there are things that can make it peak again throughout life. It's not just you get over it in your 20s and then you're okay for the rest of your life. It's something to be mindful that it could happen again.
Depression is almost always a recurrent illness. It's a chronic illness, and in fact, right now, it's the number 2 most chronic illness, and it is the most expensive chronic illness. And the biggest cost in depression is not the cost of seeing doctors or even medication or hospitals. The biggest cost is in disability payments. And if you look at some of the studies, about 90% of people who have depression define it as being at least moderate intensity to very severe. So most cases are more severe. So it's a very, very disabling illness.
Let's pause for just a moment to thank our sponsors.
Imagine being able to recover from an illness or an injury in the comfort of your own home. Perry Memorial Hospital now offers professional care from our door to yours. Perry Home Care provides skilled nursing, medical rehabilitation, and education for a safe and comfortable recovery. To learn more, visit perrymemorial.org/homecare. We listen, we care, we are Perry.
So let's talk specifically about seniors. How prevalent is it amongst seniors?
The lifetime prevalence for somebody who's over the age of 65, that means if you're 65 or over, what's the chances that before you pass away that you're going to develop an episode of major depression? It's somewhere between 15 and 25%, so it runs a little bit higher than it does in the younger population.
Now, mental health overall just kind of has this big stigma. I think just now people are getting to the point of talking about it more and recognizing how much of a problem that it can be for a lot of people. And TV and movies really do a lot in driving what people's perception of mental illness is. So a lot of times it's just taking, quote unquote, a happy pill taking that for the rest of their lives. What's wrong with how it's presented through TV and movies?
Well, I think that sometimes in television and movies, they tend to present a very unrealistic view of what depression really looks like. For example, One Flew Over the Cuckoo's Nest. People tend to think about shock treatments in that way, when in fact, shock treatments or electroconvulsive therapy is actually a very advanced, technologically done thing through computers and so forth, and people respond very nicely to it. But I think the big thing that we really have to take away from this discussion today is that major depressive disorder is a chronic illness, and it does require ongoing treatment for the rest of your life.
Now, I don't want to get too off track here, but I had no idea that the electro therapy like that's something that's still done.
Electroconvulsive therapy is done quite frequently. I practice in the St. Louis area, and I'm sure that there's at least a couple hundred treatments going on every day.
Well, that's not something that, as of right now, is done here at Perry, but I do want to talk a little bit about the Senior Behavioral Wellness Program. It's one of the resources we have specifically to help seniors. Can you explain a little bit about the program, how it works, and why we have it?
Sure, I'd be glad to. Our Senior Behavioral Wellness Program is really an outpatient geriatric program, so we do treat seniors. They don't necessarily have to be over the age of 65. Patients can self-refer, or they can be referred by a social worker or their primary care provider. It doesn't really matter. Most of the patients that we treat are patients who are really suffering from major depressive disorder. We do see some people who have bipolar disorder. We may see some people who have schizophrenia. We see a lot of people who have secondary illnesses, anxiety disorders, very commonly panic attacks or panic disorder. We see a lot of generalized anxiety disorder that is comorbid with the depression. But the bread and butter of what we do is we treat older patients who have major depression. And the way the program works is that they get to see me for an evaluation. Initially, they're screened, though, by our program director, Angie. And after that's all done, then they're seen by me, and I do that through the telehealth services. And at that time, I formulate a treatment plan, which involves medication. I also direct the amount of therapy that patients are going to receive. We offer group therapy, we offer individual therapy, and most patients get some combination of both of those therapies. Our patients typically remain in the program for several months. They usually come 2 to 3 times per week, and they may be in the program for 3 to 4 months before they're discharged. And hopefully through the therapy, they learn better coping skills, they learn better strategies to deal with stresses that tend to kind of promote their depression. And hopefully the medication that we're able to get them on is a big help in getting them toward remission, because our goal is always to try to treat depression to remission.
Angie likes to put a lot of emphasis on the group therapy and the importance or the value that brings to patients through their treatment. Why is it that group therapy is so valuable?
Well, I think therapy in general is very, very valuable. Most of the studies that have been done over the last 30 or 40 years have consistently shown that the combination of medicine and therapy is the best way to go in terms of treating depression. The thing about the group is that not only does an individual get feedback from the group leader, who in our case is a licensed therapist, but they also get some feedback from their peers, and that turns out to be very, very helpful. So in group therapy, people learn a lot about themselves through the feedback that they get, but the group also teaches them coping skills. A lot of people tend to be very passive, and for example, they may learn assertiveness skills in group. And so they're able to say no to people and not take on so much and get overwhelmed. And that's a very important tool.
For anyone listening who wants more about these resources, on the webpage for this episode, I'm going to put links to Senior Behavioral Wellness. We've got the Grief and Loss support group that happens each month, as well as for anyone who is not 65 or older and they still want some help, we do have some counseling services available through the Family Health Clinic. So I'll make sure all those resources are available if you go to www.perrymemorial.org/podcast and find this episode. You'll be able to see all those resources and also find out more information about Dr. Arba and read the details of this episode, listen to it again, share it with friends. Thanks so much for joining us, Doctor.
Thank you for having me. I've enjoyed it.
It doesn't stop here. access other podcast episodes and resources related to today's episode by visiting www.perrymemorial.org/podcast.